Welcome to The Explainer. Today, we're diving deep into the complex clinical world of COPD exacerbations. We're going to break down everything from the patient's presentation and diagnosis all the way through to treatment and the long-term fallout.
So here's our game plan. We'll start with the fundamentals of a COPD exacerbation, then move into the detective work of identifying pathogens and tackling resistance. After that, we'll cover treatment protocols, the public health side of things, and finally wrap up with a quick knowledge check to make sure it all sticks.
All right, Section 1, the basics. First things first, let's establish a really clear working definition of what a COPD exacerbation actually is and what's lighting the fuse.
Okay, so the single most important point here is that an exacerbation is not the patient's normal. It's an acute event. It's a distinct, sudden worsening of their symptoms that goes way beyond their day-to-day baseline and demands a change in their therapy. And this chart really drives home the main culprit. Somewhere between 50 and 70% of these flare-ups are sparked by an infection. And what's fascinating is that the blame is split pretty much down the middle, 50-50, between viruses and bacteria. That split has massive implications for how we diagnose and treat these patients.
Section 2, pathogens and resistance. So, if we know infections are the primary trigger, the next logical step is the diagnostic hunt for the specific bug. And, as we'll see, this is where we run into the ever-growing challenge of antimicrobial resistance.
The investigation starts with the usual suspects. Now, while Streptococcus pneumoniae is the king of community-acquired pneumonia in general, here's the critical distinction. Haemophilus influenzae is way more common in our patients who have underlying COPD. And of course, we always have to keep gram-negatives and the so-called atypicals on our radar. Now this slide shows a night and day difference in our diagnostic tools for something like Legionella. A PCR from a respiratory sample, we're talking over 97% sensitivity. The urinary antigen test, which is used all the time, just under 52%. The data couldn't be clearer. Molecular diagnostics are just vastly superior for this particular pathogen.
And here we have a trend that is, to put it mildly, deeply concerning. We're looking at a 5-fold jump in carbapenem resistance in Klebsiella pneumonia in just 4 years. This isn't random. It's being driven by the relentless spread of carbapenemase encoding genes, that whole alphabet soup, like BLA-OXA48, that's becoming a real headache in labs everywhere. So after that lovely alphabet soup of resistance genes, let's talk about treatment. Why did the antibiotic get a promotion? Because it showed outstanding resistance to being mediocre. All right, back to the series protocols. Section 3 is all about our therapeutic arsenal. Now, the very first rule of treatment is good stewardship. We don't just jump to antibiotics. Therapy should really be reserved for patients with clear objective signs of a bacterial infection. We're talking fever with purulent sputum, or you see something on the chest X-ray. Of course, clinical judgment is still key, especially for our sicker, high-risk patients.
This table gives us a great snapshot of first-line therapies for adults. For a run-of-the-mill bacterial COPD exacerbation, oral doxycycline is a really solid choice. If we nail down the specific pathogen, we can tailor the therapy even more. And obviously, for severe cases landing in the ICU, we get aggressive with IV regimens. Now, this is for adults. It's worth remembering that treating community-acquired pneumonia in children is a different playbook, usually starting with weight-based dosing of amoxicillin.
Okay, let's zoom out from the individual patient now and look at the bigger public health picture. We're talking infection control and mandatory reporting.
Now, you might be looking at this and thinking, poliovirus? What's that got to do with COPD? Well, while it doesn't cause these exacerbations, it serves as a perfect blueprint for the kind of rigorous, multi-agency communication chain that is absolutely essential for containing any high-consequence biological event. The principles are universal. But here's the rub. Ideal protocols often crash into the wall of reality. This quote gets right to the heart of a huge barrier. The principle of isolating patients with transmissible respiratory bugs is fundamental. But in the real world, whether it's a long-term care facility packed with COPD patients or another crowded setting, the infrastructure just might not be there to do it properly. This principle of urgency is universal.
Just as an analogy for how time-sensitive this can be, think about HIV, post-exposure prophylaxis. That therapeutic window is incredibly tight. It's a stark reminder that for any potential pathogen exposure in a clinical oral lab setting, fast, protocol-driven action is everything. Treating the acute infection is often just the first battle. In this next section, we have to look at the potential cascade of complications and the very real possibility of lasting damage. The specific bug that triggers the exacerbation can completely change the game. For instance, when that trigger is SARS-CoV-2, the risk of thrombosis just skyrockets. These statistics from COVID-19 are, frankly, astounding. It shows that for certain viral triggers, managing the patient's coagulation system becomes just as important as managing their breathing. And that aftermath can stretch on for months. We now have a clear timeline from the WHO that defines post-COVID syndrome. This is a very real, long-term complication for patients, including those with COPD, where symptoms either drag on or pop up brand new months after they've cleared the initial infection. All right, let's bring it all together. For our final section, we've got a quick knowledge check to help lock in some of the most critical clinical points from this whole explainer.
Okay, question 1. Picture this scenario. A 78-year-old in a nursing home has COPD and now has pneumonia. What's on your list of likely bacterial culprits, including the atypicals you need to be thinking about?
And the answer requires you to consider the intersection of all those risk factors. You've got your classics like S. pneumoniae and H. influenza, of course. But given the age and the setting, you absolutely have to have the atypicals, Mycoplasma and Chlamydophila, on your differential.
And our second question, this one goes right to the heart of good antimicrobial stewardship. When do you actually pull the trigger on antibiotics for a COPD flare-up?
And the crucial takeaway here is discipline. Antibiotics are not a knee-jerk reaction. You wait until you have clear, objective evidence of a bacterial driver. And when you do make that call, the evidence strongly supports oral doxycycline as an excellent first-line choice.
And this brings us to one last big question to chew on as we stare down a constantly evolving microbial landscape. With pathogens getting smarter and resistance on the rise, we have to constantly ask ourselves, are our current playbooks enough to keep up? Thank you for joining this explainer.